Hello and welcome back to the Deep Dive. It is Friday, January 16th, 2026, and today we are doing something a little different. We are putting on the scrubs, walking into the operating theater, and tackling a subject that feels small. I mean, literally the size of a grain of rice, but its complexity is it's massive.
It really is.
We are looking at Chapter 56 of Baily and Love's Short Practice of Surgery, the 28th edition.
We are indeed. And I think for a lot of people, even in medicine, the parathyroids are kind of this afterthought in med school. You spend months on the heart, weeks on the liver, and then, maybe 20 minutes on these 4 little yellow dots in the neck.
Exactly. But as we went through this chapter, it became so clear that this is a high-yield minefield for surgeons. So the mission today is pretty simple. We're going to create an audio-ready reckoner.
Right.
If you're a medical student, a surgical trainee, or just someone fascinated by how the body regulates itself, this is your deep dive into the parathyroid glands.
We're going to try and move beyond just the textbook definitions and really get into the head of the surgeon. We need to understand not just where these things are, but why they're there and, how to find them when they decide to go rogue.
And just to set the ground rules, we are interpreting this chapter. We're pulling out the must-know facts, the surgical pearls, the logic, but we are not reading it verbatim. We want you to use this as a revision guide.
Please, open the actual book.
Yes, look at the diagrams. Treat this as your companion piece.
Absolutely. Think of us as your study partners who've already gone through with a highlighter.
So if you're driving to the hospital or hitting the gym before a shift, treat this as an active study session. We're actually going to have check-in checkpoints along the way.
Oh, I like that.
Yeah, where I'll ask you a question just to see if the concept's stuck.
Good idea. Active recall is the only way this stuff sticks, really.
Okay, let's get into it. And I have to start with the hook from the introduction of this chapter because it's honestly one of my favorite medical history facts.
It's a great one.
We tend to think of human anatomy as something that's been, settled for thousands of years, right? Like the Greeks knew about the liver.
Oh, yeah. The liver, the heart, the lungs. This is ancient knowledge.
But not the parathyroids. According to Baily and Love, the parathyroid glands weren't even described until 1850. And the discovery didn't even happen in a human.
No, it didn't. It was Sir Richard Owen, the famous anatomist. He was the guy who actually coined the word dinosaur, which is a fun fact.
Right.
And he was performing an autopsy at the London Zoo.
On an Indian rhinoceros.
An Indian rhino. I mean, can you imagine? He's dissecting this massive animal, and he finds this small, compact yellow gland in the neck that looks totally distinct from the thyroid. He logs it. And that is the moment science really registers the parathyroid.
And it took another 30 years before a Swedish medical student named Sandström actually described them in humans.
Which is such a tragic story.
It really is. As the text notes, his work was just ignored by the medical establishment. He sadly committed suicide at a young age, never knowing how important his discovery was.
And it wasn't until later, when surgeons started doing thyroidectomies and patients started getting tetany, these awful, uncontrollable muscle spasms, that people realized, wait a minute, we must have removed something vital.
It just highlights how relatively new this anatomy is. We're talking barely over 100 years of really understanding what these things do.
So, yeah, a lot to cover.
Okay, so here is our roadmap for this deep dive. We're going to break this down into 4 main parts. First, anatomy and embryology. And we have a great metaphor to help you remember the positioning.
Good.
Second, the physiology, we're calling it the calcium seesaw. Third, primary hyperparathyroidism, which is the absolute bread and butter of this kind of surgery. And finally, the renal connection and the zebras, the rare cancers and genetic syndromes.
Sounds good. Let's start with part 1, anatomy, or as I like to call it, the search for the Portland brick.
The text uses that very specific visual description, which I love. When you open a surgery textbook, usually the first thing isn't the color of the organ, but here it really matters.
It matters immensely. I mean, if you're a surgeon digging around in a bloody neck incision looking for a gland that's only about 30 milligrams, you need a visual anchor.
And that anchor is?
Baily and Love describes the color as a Portland brick, yellow-brown.
Yellow-brown. Okay, so not red like muscle, not pale like fat.
Exactly. And they are tiny, 30 milligrams. To give you a sense of scale, a standard paperclip weighs about a gram, so 1,000 milligrams.
Yeah.
We are talking about something 1/30th the weight of a paperclip.
And there are usually 4 of them.
Usually. But this is surgery. So usually gets you into trouble.
Yeah.
The text notes that about 13% of people have some kind of abnormal parathyroid tissue, and 5% have a supernumerary gland.
A fist gland.
Fifth gland. And that 5% is a crucial number to remember if you're a surgeon and you've taken out 4, but the patient is still sick.
Yeah.
You have to keep looking.
Okay. Now, let's talk position. This is the part that trips up every medical student, because the names, superior and inferior, don't seem to match the embryology. We need a metaphor. I like to think of the glands as 2 different types of people, the traveler and the homebody.
I see where you're going with this. This is about the pharyngeal pouches.
Exactly. So let's start with the inferior parathyroid glands, the ones at the bottom. In embryology, these arise from the 3rd pharyngeal pouch.
Correct. And they don't travel alone. They arise from the 3rd pouch along with the thymus.
And the thymus has a long commute, right? It has to go all the way from the neck down into the chest, into the mediastinum. So because the inferior glands are buddies with the thymus, they are the travelers, they get dragged along for the ride.
That is the absolute key insight. Because they travel further during development, their final resting place is highly variable.
So they could be anywhere.
Well, Baily and Love says that while more than 50% are found at the inferior pole of the thyroid, they could be found inside the thymus, way down in the mediastinum, or really anywhere along that path of descent.
So inferior gland equals 3rd pouch equals traveler equals variable position. Okay. Now, contrast that with the superior parathyroid glands.
The superior glands arise from the 4th pharyngeal pouch.
These are the homebodies.
They are. They travel much less. They don't have this, long-distance relationship with the thymus. Because they have a shorter embryological journey, their position is remarkably constant.
How constant?
The text says that in 80% of patients, the superior glands are found on the posterior aspect of the thyroid lobe.
And there's a specific landmark mentioned, isn't there? A kind of surgical intersection.
Yes, this is gold for any trainee. If you're digging in the neck, you look for the intersection of the inferior thyroid artery and the recurrent laryngeal nerve. The superior gland is usually within a 2-centimeter circle of that junction.
That is a golden rule for the OR. Okay, superior gland equals 4th pouch equals constant position. Inferior gland equals 3rd pouch equals variable position.
And there's one more anatomical fact that's critical for dissection: the blood supply.
Ah, yes.
Despite their different origins, both the superior and the inferior glands are typically supplied by the same artery, the inferior thyroid artery.
Which means
It means you have to be careful. If you're a bit cavalier and you ligate that artery too far proximally, you risk devascularizing all the glands on that side. You could make the patient permanently hypoparathyroid.
okay, that simplifies things but also raises the stakes.
Right, we've arrived at our first check-in checkpoint. If you're listening, pause and try to answer this in your head before we do.
Here's the question.
Quick check. Which pharyngeal pouch do the inferior glands come from? And why does that embryological origin make them harder for a surgeon to find? Okay, you got an answer.
The answer is the 3rd pharyngeal pouch. And because they originate with the thymus, the traveler, they migrate much further down the neck, making their final anatomical position way more variable than the superior glands.
Nailed it. If you got that wrong, seriously, just rewind a minute and listen to the traveler versus homebody bit again. It's crucial. Let's move on. Part 2, physiology, the calcium seesaw.
This is such a delicate balancing act. The parathyroid glands produce PTH parathyroid hormone. It's an 84 amino acid peptide. And what pulls the trigger? What makes the gland spit out PTH?
The primary trigger is low serum calcium, specifically ionized calcium. There's a secondary trigger: high serum magnesium can affect it. But really, for all clinical purposes, low calcium is the key.
And PTH has 3 jobs. It's like a specialized task force with 3 distinct targets.
The trio, exactly. Target 1 is the kidney. PTH tells the kidney to hold on to calcium, so increase reabsorption. It also tells the kidney to dump phosphate. This is important. Calcium goes up, phosphate goes down.
And the kidney has a little side hustle here too, right?
A crucial side hustle. The kidney activates vitamin D. It takes the inactive 25-hydroxyvitamin D and it hydroxylates it, turns it into the active 1025-dihydroxyvitamin D.
Which leads us directly to target 2, the gut.
Right. That active vitamin D is what tells the gut to absorb more calcium from your food. PTH doesn't talk to the gut directly. It uses vitamin D as the go-between.
Okay, and target 3, the big bank vault.
The bone. PTH stimulates the bone cells, both the osteoblasts and the osteoclasts, to increase their turnover. Basically, it unlocks the vault to release calcium from the skeleton into the blood.
So, kidney saves calcium, gut absorbs calcium, bone releases calcium, all to get that blood level up.
Precisely. And just to be complete, there's the antagonist calcitonin. It's secreted by the parafollicular C cells of the thyroid. It does the opposite, tries to lower calcium. But in human physiology, PTH is really the dominant driver.
Okay, groundwork laid. Now we get to the really clinical stuff. Part 3, primary hyperparathyroidism, or PHPT.
This is the most common reason a surgeon is going to be dealing with these glands.
And the presentation has evolved so much, hasn't it? Back in the day, they had that famous rhyme for the symptoms.
Bones, stones, abdominal groans, and psychiatric overtones.
I love that. It sounds like something out of a haunted house movie.
It does. And it refers to the really severe end-stage disease. Bones for fractures, and these things called bone cysts. Stones for kidney stones. Groans for pancreatitis and ulcers. Psychiatric overtones for depression, confusion.
The text mentions the first patient ever operated on for this. Albert Gahn, a tram conductor in Vienna in 1925.
Yes, operated on by a surgeon named Felix Mandl. That poor man had severe bone disease, what they called osteitis fibrosis cystica. He was breaking bones just walking around or stepping off the tram.
Unbelievable.
And Mandl went in, he removed a parathyroid tumor, and the calcium normalized. It was, a miracle at the time.
But today, if a surgeon expects to see a tram conductor crumbling to pieces, they're going to miss 99% of the cases.
Exactly. The modern reality is that most patients are asymptomatic. We find them because we run these automated blood panels that check calcium. You go in for a cholesterol check and, oops, your calcium's a bit high.
But if they do have symptoms, what are we looking for now?
Kidney stones are still the most common clinical manifestation, but also really vague stuff fatigue, muscle weakness, this neurocognitive fog. And the text highlights a specific type of bone loss.
Oh, this was interesting.
It says women often present with osteoporosis, specifically in the distal radius, the wrist.
Why the wrist? That seems so random.
It's fascinating. PTH is catabolic. It eats away a cortical bone, which is the dense bone that the wrist is made of, but it's actually anabolic. It builds up cancellous or spongy bone, like in your spine.
So you can have a patient with a terrible wrist DEX scan, but a totally fine spine.
Exactly. And that dissociation, that pattern, is a real clue for hyperparathyroidism.
That is a great clinical pearl. Okay, let's talk diagnosis. The text has a golden rule here.
The golden rule. PHPT is a biochemical diagnosis, not a radiological one.
Say that again for the people in the back.
You diagnose it with blood work. You do not diagnose it with a scan. The lab profile is an elevated calcium in the presence of an elevated or maybe an inappropriately normal PTH.
And low phosphate, usually.
Correct. If you have that combination, you have the diagnosis. You don't need a scan to tell you the patient has the disease.
So why do we even scan them then?
There's a great quote in the text from a radiologist named John Dotman. He said, "The only localizing study required is to localize an experienced parathyroid surgeon."
Meaning a good surgeon can find the glands without a map.
Historically, yes. That was the bilateral neck exploration. But today, we scan to facilitate minimally invasive surgery. If we can tell exactly which one of the 4 glands is the bad one, we can make a tiny 2-centimeter incision and be done in 20 minutes.
Okay, let's talk about those scans. The workhorse is the sestamibi scan. How does that actually work?
Okay, think of sestamibi as a mitochondria magnet.
The mitochondria magnet. I like it.
Sestamibi is a radioactive tracer that gets absorbed by mitochondria. Now, the thyroid has mitochondria, so it lights up initially. But parathyroid adenomas are packed with these cells called oxyphilic cells, which are absolutely stuffed to the brim with mitochondria.
So they just soak it up and hold on to it.
Exactly. The tracer washes out of the normal thyroid tissue pretty quickly, but the parathyroid adenoma stays bright. It has a delayed washout. That's the hot spot you're looking for.
Can we also use ultrasound?
Ultrasound is great for the neck, but it's terrible for the chest. You can't see behind the sternum or through bone, so if you have an ectopic gland in the diastema, ultrasound will miss it.
And the new kid on the block is 4D CT.
Yeah, 4D CT is fantastic. It's a CT scan where the 4th dimension is time. It uses the timing of contrast, how quickly it washes in and out, to distinguish a gland from a lymph node. It's very sensitive, but it does come with a higher radiation dose.
Okay, so we've diagnosed it biochemically, we've localized it, now we operate. What are we usually dealing with?
85% of the time, it's a single adenoma. Just one bad apple. About 15% of the time, it's multi-gland hyperplasia. All 4 are acting up.
And who gets surgery? If I'm asymptomatic with slightly high calcium, do I still need an operation?
There are pretty clear consensus guidelines, which are in Table 56.2 in the text. Basically, you operate if you're under 50 years old.
Okay, young patients.
If your calcium is significantly high, more than 0.25 millimole L above the normal range, if your kidneys are suffering, so your GFR is less than 60, if you have kidney stones, or if you have osteoporosis with a T-score less than -2.5.
So young, stones, bones, or groans, essentially.
Exactly. And the technique is usually a MIP, minimally invasive parathyroidectomy. You go in, take the one gland that lit up on the scan, and get out.
But how do you know you got the right one? Or that there isn't another one hiding?
That is where the Miami criteria come in. This relies on the fact that PTH has a very, very short half-life, about 3 to 5 minutes.
So it disappears from the blood really quickly.
Right. So you take the gland out, you tell the anesthesiologist to wait 10 minutes. You draw blood from the patient right there on the table. If the PTH level has dropped by more than 50% from what it was at the start of the case, you win. You can close up.
That is amazing. That's instant gratification surgery.
It really is. It's one of the few times in tumor surgery where you get confirmation before the patient even wakes up.
Okay, time for checkpoint 2. Let's apply this.
Ready.
All right, here's a scenario. You have a patient with high calcium, but their PTH level is low. It's actually suppressed. Is this primary hyperparathyroidism? And the bonus question, why does the sesame B scan work? What's the verdict?
Okay, if the PTH is suppressed, it is not primary hyperparathyroidism. In PHPT, the gland is ignoring the calcium and pumping out hormone. If the gland is turned off, low PTH, but the calcium is still high, you have to think about malignancy.
Like what?
Like a bone metastasis or multiple myeloma that's just leaching calcium out of the bones. The parathyroids are behaving appropriately. Something else is driving the calcium up.
Okay. And the scam.
Sesame B works because adenomas are packed with mitochondria-rich oxyphilic cells, which hold on to the radioactive tracer much longer than the normal thyroid does. It's the mitochondria magnet.
Excellent. Let's move to part 4. Secondary and tertiary hyperparathyroidism. This is where the kidneys really enter the chat.
Yeah, this is a completely different mechanism. In primary disease, the parathyroid is the criminal. In secondary disease, the parathyroid is the victim, at least at the start.
It begins with chronic kidney disease, CKD.
Right. The kidney fails. Remember those jobs the kidney had? It stops dumping phosphate, so phosphate rises. And it stops activating vitamin D, so you can't absorb calcium from your gut.
So the serum calcium drops.
And because the calcium drops, the parathyroid glands, they just scream, they undergo hyperplasia, all 4 of them get bigger and pump out massive amounts of PTH to try and fix the low calcium.
So they're just doing their job, but they're stuck in overdrive.
Exactly. That is secondary HPT. The glands are just responding to a physiological stimulus. They're not the primary problem.
And there's a nightmare scenario associated with this called calciphylaxis.
Ugh. This is one of the most terrifying conditions in all of surgery. It's formally called calcific uremic arteriolopathy.
What is it?
Basically, the calcium and phosphate balance is so profoundly deranged that the minerals literally precipitate out of the blood and calcify the small blood vessels in the skin and fat.
The vessels turn to stone.
Essentially. And because the vessels clot off, you get ischemic skin necrosis, gangrene, usually on the legs or abdomen. It is unbelievably painful and has a mortality rate of up to 87%.
87%. That is catastrophic.
It is. If you see this, it is a surgical emergency. You have to normalize that calcium phosphate product immediately, and that often means an urgent total parathyroidectomy.
Wow. Now, speaking of surgery for secondary HPT, if the drugs like cinacalcet or phosphate binders don't work, we operate. But we can't just take one gland because all 4 are hyperplastic.
Correct. You have 2 main options. Option A is a subtotal parathyroidectomy. You remove 3.5 glands. You leave a little nub about 50 milligrams of the most normal-looking gland behind, so the patient isn't permanently hypocalcemic.
And option B involves the forearm?
Option B is a total parathyroidectomy with autotransplant. You take all 4 glands out of the neck, you chop one of them up in little 1 millimeter cubes, and you literally plant those pieces inside the muscle of the patient's non-dominant forearm.
The forearm? That sounds like science fiction. Why on earth the arm?
It's purely strategic. Remember, these patients still have kidney failure. The physiological drive, the high phosphate, is still there, so that transplanted tissue might grow back and become overactive again.
Ah, and if it does?
If it recurs, would you rather go back into a scarred-up neck with the recurrent laryngeal nerve hiding in there, or would you rather make a small cut on the forearm under local anesthetic and just take a few of those pellets out?
The forearm, every single time.
Exactly. It makes any future problems so much easier to manage.
Brilliant. Now, briefly, what is tertiary hyperparathyroidism?
Tertiary is what happens after you fix the kidney failure. The
Right.
patient gets a successful renal transplant. But the parathyroid glands have been driven so hard for so long that they just refuse to turn off. They've become autonomous.
So the driver is gone, but the car is still speeding down the highway.
Perfect analogy. And the treatment for that is usually surgery, a subtotal parathyroidectomy.
Checkpoint 3. Let's lock this in.
Go for it.
What is the key electrolyte imbalance in kidney failure that starts the whole chain reaction for secondary HPT? And what is the name of that skin necrosis emergency?
Got it.
Got it. The trigger is phosphate retention, hyperphosphatemia, which then causes low calcium, and the emergency is calciphylaxis.
You are doing great. We're in the home stretch now. Part 5, the zebras, the rare but important stuff. Let's talk about parathyroid carcinoma.
This is very rare. We're talking less than 1% of cases of PHPT, but you do not want to miss it because the surgery is totally different.
How do we spot it? What are the clues?
The clinical picture is just much more aggressive. In a benign adenoma, the calcium is high, but in carcinoma, it is extremely high, often over 3.75 millimole. The PTH is 5 to 10 times the upper limit of normal.
And the physical exam. This is a key differentiator. Benign adenomas are soft and almost never palpable. If you can feel a hard mass in the neck of a hypercalcemic patient, you have to be worried about cancer.
The text mentions a specific gene here.
Yes, the HRPT2 gene, which codes for a protein called parafibromin. Loss of parafibromin standing on pathology is a very strong indicator of cancer.
And the surgery is different too. You can't just shell it out like an adenoma.
No, absolutely not. If you rupture the capsule of a carcinoma, you spill tumor cells and they will seed the entire neck. It's a disaster. You have to do an en bloc resection, take the gland, the adjacent thyroid lobe, and any involved muscle, all in one single piece.
High stakes. Okay, let's touch on genetics. The MN syndromes.
Multiple endocrine neoplasia.
MN1. The text calls it the 3PS.
Parathyroid, pancreas, pituitary. Parathyroid is the most common feature. It's in almost all of them. And in MN1, it's always multi-gland disease. You're usually doing a subtotal or total resection.
And MN2A.
This is the dangerous one if you're not paying attention. MN2A includes medullary thyroid cancer, parathyroid issues, and pheochromocytoma.
And why is that so dangerous?
Because if a patient has an undiagnosed pheo, an adrenaline-secreting tumor on their adrenal gland, and you put them under anesthesia for their next surgery, the stress can trigger a massive hypertensive crisis. You can kill them on the operating table.
So the rule is, rule out pheo first.
Always, every time.
Now, there's one genetic condition that is a massive trap for surgeons, FHH.
Familial hypocalciuric hypercalcemia.
That is a mouthful.
It is. And here's the scenario. You see a patient with mild high calcium and a normal to high PTH. Looks exactly like primary hyperparathyroidism, right?
Exactly like it. A slam dunk for surgery.
But if you operate, you will not cure them. And you shouldn't operate. FHH is a benign condition where the body's thermostat for calcium is just set higher. The calcium-sensing receptor is broken.
So the kidney thinks the calcium is low and just hoards it.
Precisely. And that's the clue. Hypocalciuric. They have low calcium in their urine.
So before you book that young asymptomatic patient for surgery,
you must measure their 24-hour urine calcium. If it's low, it's FHH. Do not operate. You save them a scar and yourself a major headache.
We're at part 6. Complications and wrap-up. Surgery isn't without risk. What keeps a parathyroid surgeon up at night?
The recurrent laryngeal nerve, the RLN, is the big one. It runs right by the glands. If you damage it, the patient wakes up with a hoarse voice. If you damage both, you can block their airway.
And then there's hungry bones syndrome.
Yeah, this happens after you take out a big, really active adenoma. The bones have been starved of calcium for so long that when the PTH suddenly plummets, the bones act like a sponge. They just suck up all the calcium from the blood.
Causing severe hypocalcemia.
Right. Tingling, cramping, tetany. It can be quite dramatic. You have to be ready to load these patients up with calcium and vitamin D post-op.
Okay, let's do one final fictional case study to bring this all together.
Let's do it.
Case study B. You have a 25-year-old male. He presents with high calcium. He mentions his dad had some gland problems and his aunt had a jaw tumor.
Okay, stop right there.
Yeah.
Immediate red flags. 25 is very, very young for sporadic disease.
What are you thinking?
Young age plus family history suggests a genetic syndrome. And the specific mention of a jaw tumor points directly to HPTT-JT hyperparathyroidism jaw tumor syndrome.
Which is linked to that carcinoma gene, right?
Yes, the HRPT2CDC73 gene. So this patient has a high risk of both parathyroid carcinoma and these weird cystic parathyroid adenomas.
So do you offer him a minimally invasive scan-directed operation?
Absolutely not.
Yeah.
He needs a formal bilateral neck exploration.
Yeah.
You need to look at all 4 glands. And you need to be exceptionally gentle because of that cancer risk. No rupturing any capsules.
Perfect. Final checkpoint.
Ask away.
We just talked about it, but it really bears repeating. Why must we measure urine calcium in a young, asymptomatic patient before we even think about surgery?
To rule out FHH, familial hypocalciuric hypercalcemia. If the urine calcium is low, it's FHH. It is a benign condition. Surgery is not indicated and it will not help them.
Fantastic.
We have covered a lot of ground there.
We have. We went from the Indian rhino to the Portland brick. We covered the traveler versus homebody embryology. We balanced the calcium seesaw.
We diagnosed PHPT biochemically, not radiologically. We talked about the renal cascade of secondary disease, and we flagged all the zebras like carcinoma and the MN-DIN syndromes.
Baily and Love, Chapter 56. Consider it interpreted.
It's a dense chapter, for sure, but the logic is really beautiful once you see the patterns.
I want to leave our listener with one provocative thought. We mentioned things like the Casanova test, using venous sampling in the arm to find a recurrence. It's a very clever physiological test.
It is. It relies on understanding the body, not just looking at a picture.
But the text notes that this is becoming rare because our imaging is getting so good. 40 CT, better sesame. So my question is this. As technology gets better and better, are we losing the art of surgery? Will the physical exam and these old-school physiological tests just disappear entirely? Or does the true master surgeon still lie in knowing when to look rather than just how to scan?
That's the million-dollar question, isn't it? I think the master surgeon uses the scan, but trusts the physiology. At the end of the day, you can't operate on a JPEG. You operate on a patient.
Well said. Listeners, if you have a copy of Baily and Love, do yourself a favor. Open up Chapter 56 and look at Figure 56.1. Seeing that diagram of the embryological descent will lock that traveler metaphor in your brain forever.
Absolutely. Good luck with your studies and scrub in with confidence.
Thanks for listening to The Deep Dive. We'll see you next time.